Non-full thickness macular holes. A closer look. Macular pseudohole and lamellar macular hole were originally described by Gass as two different entities. However, although Gass presented each disease in a different chapter, in his schematic drawings of both diseases he included epiretinal membranes, which do not cover the center of the fovea. Spectral domain OCT gives us new possibilities to describe and observe the disease. Thanks to the great number of B scans achieved on the surface of the retina, we can create an artificial image of the retina. Three-dimensional images of the pathology are also available. With spectral domain OCT, we observe that the fovea is on the level of the outer plexiform layer in a normal healthy retina. If we look at an eye with macular pseudohole, we can see that the fovea depression remains in its place. However, the outer plexiform layer is pulled above this level, probably through the traction of epiretinal membrane. By examining central B scans, we can distinguish four different types of non-full thickness macular holes: macular pseudohole, pseudohole with lamellar defects, paralamellar macular hole, lamellar macular hole. If we look at different B scans taken during a single examination of a non-full thickness macular hole, we can observe different manifestations of the disease on individual B scans. The three-dimensional spaces inside the retina that are associated with the disease are presented in this animation. This is another argument that all presented types are different manifestations of the same disease. Additionally, if we study the disease during follow-up using an SD-OCT device with eye tracking, we see that during the maturation of the epiretinal membrane, a lamellar macular hole is created from the macular pseudohole. This is even more clearly shown in this animation. Focal traction is a very probable cause of the primary appearance of retinal defect. Release of traction also causes slight defects, probably focal removal of ILM on the surface of the retina. Then, interretinal changes may develop together with epiretinal membrane formation. This animation presents lamellar macular hole formation and healing after surgery. This process is somehow different from full-thickness macular hole formation, where traction on the fovea is much wider and creates fovea elevation as an initial step. To summarize these events, we have created an animation presenting their sequence in the process of formation of non-full thickness macular defect. Focal vitreomacular traction, focal ILM removal, creation of interretinal defect together with epiretinal membrane formation, increase of size of a non-full thickness macular hole during maturation of epiretinal membrane, which causes elevation of the macular surface. If we examine clinical appearance, we can confirm the presence of vitreoretinal traction as an early step of the disease. Vitrectomy is performed. After staining of the retinal surface, we confirm that neither epiretinal membrane nor ILM are present in the center of the fovea. During combined removal of epiretinal and ILM complex, we see this hole in the tissue, and we see the margin of the ILM around the non-full thickness fovea defect. Another case of macular pseudohole presents the removal of ILM and ERM complex in toto around the fovea. After complete removal of this complex, a hole in the membrane is demonstrated, which corresponds with its previous position over the fovea. Once again, in another case, we see epiretinal membrane present on the retinal surface, but not covering the fovea center. We believe that the only explanation as to why epiretinal membrane in these cases does not cover the fovea center is a defect in the ILM, primarily caused by traction. This central defect is also confirmed by epiretinal membrane removal. After surgical treatment of non-full thickness retinal defects, we may observe the following: normalization of the fovea contour, slight deformation of the macular contour, persisting pseudohole, persisting lamellar macular hole. All are without epiretinal membrane. Finally, we can observe similar non-full thickness fovea defects in an eye where nutrition from the choroid to the central retina is defective, like in age-related macular degeneration or diabetes. In these eyes, we usually observe no epiretinal membrane, but advanced pathologic changes in the subretinal tissue. Conclusions. Despite idiopathic non-full thickness macular holes having various, slightly different appearances in spectral domain OCT B scans, macular pseudohole and lamellar macular hole should be considered as one disease. They are probably caused by focal traction and focal ILM defects in the center of the fovea and should be considered as a subtype of epiretinal membrane formation. However, in secondary cases with subretinal diseases, similar appearances of non-full thickness macular hole may be present. In these cases, advanced subretinal pathology and the presence or lack of epiretinal membrane allows us to distinguish both types.